This is Outbreak News This Week, brought to you by the Global Dispatch Incorporated. Outbreak News This Week is your source for all the news about worms and germs. And now, your host, microbiologist and editor of OutbreakNewsToday.com. Here's Robert Harriman.
Well, good day, Tampa Bay, and welcome to today's show. Now, here at the website, here at the radio show, we've been keeping a close eye on the measles situation going on up in the New York City area, right? You got a pretty big outbreak up there in the Brooklyn, Queens boroughs, where it's now well over 200 cases in just a few short months. And a lot of these cases really revolve around and involve members of the Orthodox Jewish community. But over in Rockland County, and they have about 153 cases as of Thursday. The county executive, his name is Ed Day. He declared a county-wide state of emergency relating to this outbreak. And it was effective at the stroke of midnight on Wednesday, March 27th, that anyone under the age of 18 and that was unvaccinated against measles would be barred from public places until this declaration expires in 30 days or until they receive the MMR vaccination. Day says, and I quote, "Every action we have taken since the beginning of this outbreak has been designed to maximize vaccinations and minimize exposures. We are taking the next step in that endeavor today. This is an opportunity for everyone in our community to do the right thing for their neighbors and come together. We must do everything in our power to end this outbreak and protect the health of those who cannot be vaccinated for medical reasons and that of children that are too young to be vaccinated." So essentially, the public places are defined as a place where more than 10 persons are intended to congregate, like in civic or governmental, social, or religious functions. For recreation or shopping, are restaurants, food and drink consumption, are places where you're waiting for transportation or going to daycare or, medical treatment. So, yeah. So that's drew up a little bit of controversy, as you can imagine. And then we're going to look at the legalities in a moment, but first I want to play a clip from local news sources up there, a short one that talks a little bit about this. Clip number 1, Michael.
What's being called the nation's worst and longest measles outbreak in decades, prompting a state of emergency declaration in New York's Rockland County. 153 cases reported there in just the past 6 months, most in unvaccinated people. Now officials trying to keep the disease from spreading, barring anyone younger than 18 who isn't vaccinated from all public places, including schools, places of worship, and stores.
The focus of this effort is on the parents of these children. We are urging them, once again, now with the authority of law, to get your children vaccinated.
The CDC says more than 300 measles cases have been reported in 15 states this year, with confirmed outbreaks in Washington, California, and Michigan. Detroit alone has identified 22 cases in just the past 2 weeks.
It's kind of scary. It's kind of concerning.
Measles is highly contagious and can linger in the air where an infected person has coughed or sneezed for up to 2 hours. Which is why one Northern California community is on alert. Officials in Santa Clara County warning residents about possible exposure after a tourist with measles made several stops, including at stores and restaurants in the area.
Our message is, if you're not one of the majority who's protected and you might have been exposed, to know what the symptoms are and watch for them.
And those symptoms include rash, fever, and cough, and can lead to long-term health issues. And since there is no treatment, officials are again stressing the importance of getting vaccinated. Marcy Gonzalez, ABC News, Los Angeles.
Well, the website Helio, they interviewed a vaccine law expert. His name is Brian Dean Abramson. And to get a better understanding of why this decision was made and its legal and public health implications. And so their first question for him was, has a state of emergency like this happened before? Now, according to Abramson, in terms of a general restriction on unvaccinated people in public places, it is not something that has happened recently, but it is something that has happened frequently in American history. These were not necessarily made with respect to unvaccinated populations. Specifically, when outbreaks occurred when smallpox was prevalent, there were certainly periods when the entire population was instructed to stay out of public places. There were very strict regimens set up, for example, with the polio epidemic in New York in 1916, and when Spanish influenza was prevalent in 1918. There were very aggressive public measures taken to prevent people from congregating in public places where the disease might spread. It is a common thing. It is legal. And it is something that has been determined to be well within the police power of the state to regulate public gatherings during a time of an outbreak. Certainly the power to regulate that presence of unvaccinated persons during outbreaks would fall within that. It is sort of a smaller version of a general quarantine. Now, their next question was, do you think that the response to the outbreak in Rockland was appropriate? He says, I am sure that the public officials in Rockland have more accurate and more direct, up-to-date information than I have. Now, my awareness of the situation is that there have been measles cases reported. And of course, we know from history that measles can be a deadly disease in a small number of cases. Even when it's not deadly, it can lead to blindness, paralysis, or brain damage in extreme cases. Where it does not lead to the direst consequences, it can still cause someone to become really ill for a period of time. It is a very uncomfortable thing for anyone to go through. The state has not just the authority, but an obligation to protect its citizens from those kinds of dangers. Presuming that the outbreak has presented to a degree where it is reasonable to think that people who are not vaccinated may be exposed to measles and may suffer those consequences, it is entirely reasonable to take measures necessary to protect them from that. The next question asked Mr. Abramson, can an effective legal argument be made against barring unvaccinated children from public places? And he answers, the counter-argument would be that the general principle that people have freedom of movement and the freedom to gather as they wish should require demonstration of a higher degree of immediate danger before these rights can be curtailed. We voluntarily expose ourselves to certain possibility of danger every time we leave our home. Some number of people, including children, are injured every day from things like car accidents and bee stings and dog bites and exposure to pathogens for which there is no vaccine. Now, general quarantines along with the lines of the one imposed here have rarely been put in place in recent decades, and the authority granted to public health officials to impose them could reasonably be revisited in light of medical advances reducing the threat posed by specific diseases. It could further be argued that the law already sufficiently provides for the protection of children by allowing their exclusion from the schools, where a threat of infection would be most highly concentrated. And then the last question Helio had for Mr. Abramson was, how might the quarantine be enforced during the emergency? Is this an effective strategy to reduce exposure? And his answer goes like this. It is very difficult. It is a free country where people can generally move about as they please. One of the most significant enforcement mechanisms is that there would be some kind of ramification or penalty to parents who brought unvaccinated children out to places where children became infected with measles. It would be direct proof that they were unvaccinated and taken someplace where there was a risk of exposure. I think people generally follow the law when it is made known that unvaccinated persons are being required to remain out of public places. There may be some grumbling, and there may be some people who intentionally defy that and take their unvaccinated children around despite that. But I think most people, if they are aware that this is a legal measure, will follow the law with respect to that measure. Now, in some cases, this may spur parents to move vaccination to the top of their priority list and get their kids vaccinated. I should mention that the place where children congregate the most is school. We have a system set up in this country where there are exemptions in every state for medical purposes and most states for certain other reasons. The function of the exemption is to say that you can still have your child attend school even if they are not vaccinated. But in pretty much every state that has that kind of system, there are also exceptions to the exemptions. One is if there is an actual outbreak of vaccine-preventable disease for which people are not vaccinated. The school can exclude unvaccinated children during that period of time of the outbreak. For children who are unvaccinated for medical reasons, parents have most likely gone through the trouble of finding out what their child's medical circumstances are and will probably not want to expose their child to measles virus in any more than they would want to expose their child to the vaccine because of allergy or other medical conditions. For parents who have a philosophical or religious exemption, that's basically up to whether they are going to obey the law. Now, with respect to the schools, of course, they do have vaccination records for their students. So that is a place where it will be much easier to enforce the local government's determination that unvaccinated people should stay out of public places for the time being. When schools inform parents that their records indicate that the child is not vaccinated and they are in a state where unvaccinated children are prohibited from coming into public places, it is pretty good signal to the parents that they should not be bringing their child to any other public places either. So just wanted to get the legal perspective on what County Executive for Rockland, Ed Day, and his state of emergency order that was put into place Wednesday night. So interesting stuff. And, you know, the country is dealing with a number of outbreaks now, and I believe there's at least 6 states that are battling outbreaks per se, right? New York and Texas and Washington and Michigan and California, and there's another one that behooves me at this time. But yeah, this is truly going on. So we'll see how this pans out. I have no doubt that what Day did has raised eyebrows, but it's good to look at the legal perspective. And, you know, public health authorities do have some authority under these types of conditions. So we'll see. Well, our buddy Robert F. Kennedy Jr., right? He's always up to some kind of shenanigans, and here's the latest one. He has invented basically a new vaccine conspiracy theory, right? I mean, he's been behind so many of these conspiracy theories, but here's a new one. Now, after reading a CBS News article about how young people are more depressed, anxious, and suicidal than ever, Kennedy completely ignored what the scientists had to say, and that is, trends are likely linked to the cultural changes such as less sleep, less face-to-face time with family and friends. But that wasn't good enough for Kennedy, right? He came out and said, "What are we doing to our children?" in a tweet. CBS News reports sharp, unexplained rises in depression and anxiety in American teens. Shouldn't we ask whether these trends are associated with neurotoxic aluminum we are giving young teens in Gardasil vaccines? Well, the author of this article writes, well, this is a classic case of confirmation bias gone wrong and is putting people's lives at risk. Kennedy's unwillingness to accept the safety and necessity of vaccines has led him to see causation when there is none, but the real danger comes when he begins to warn others about this nonsense. In the past, right, he's an environmental attorney and a very outspoken anti-vaxxer. He's compared vaccines to the Holocaust. He has also claimed that there's an overt conspiracy within the vaccine division of the CDC. A mere month ago, amid a huge measles outbreak that left 800 kids missing school, Kennedy voiced his nonsensical views at a Washington state hearing on whether unvaccinated children should be barred from public schools. Speaking before the legislature's health committee, Kennedy erroneously claimed that the MMR vaccine had never undergone safety testing. Yeah, these vaccines go over so much safety testing; it's immense. He then began listing all the diseases he thought vaccines were responsible for, and here we go: ADD, ADHD, speech delay, autism, food allergy, autoimmune diseases. Prior to 1986, 12% of kids in this country had chronic disease. Today's 54%. Of course, none of this is true. And the MMR vaccine has absolutely undergone double-blind safety testing, considered the gold standard, right? And just this month, a decade-long study, I think it was from Denmark, of over 650,000 children found no link between MMR and autism. Again, right? It's not the first time. Again. But, what Kennedy was really attacking was the HPV vaccine. And that tweaked a few people on Twitter, particularly doctors. They were saying, stop the fear-mongering, right? You are wishing cervical cancer upon our mothers, sisters, and daughters? Shame on you. And, the thing is, there's already a ton of misinformation and straight-up lies about the HPV vaccine. And when you look at the stats, you can understand why doctors are so infuriated when somebody like Kennedy does this. HPV causes over nearly 34,000 cases of cancer in men and women every year in the U.S. According to CDC data, HPV vaccination can prevent over 90% or over 31,000 of these cancers from ever developing by preventing the infections that cause them in the first place. That's a lot of lives saved, right? And a huge weight lifted off the medical system. Not some conspiracy to make people more sick. The CDC has assured the public over and over that scientists have carefully studied the risk of HPV vaccination and that the vaccine is recommended because of the benefits, such as prevention of cancer, far outweigh the risk of possible side effects. So, yeah, it goes on and on, but that's Robert F. Kennedy Jr. doing what he does best, right? Doing what he does best. Well, last week I talked a little bit about Governor Matt Bevin in Kentucky, right? He came out and he is, they have this chickenpox outbreak up there in one of the schools, and there's a lawsuit, right? I talked about all this last week. And Bevin basically said in an interview that he purposely got all of his children purposely infected with chickenpox. So, well, that drew the ire of a lot of people, right? A lot of people on Twitter, a lot of scientists, a lot of doctors. Included in this is the Infectious Disease Society of America, the IDSA. And basically they said, what Bevin was doing is gravely concerning. Let's see what their statement says. The Kentucky's governor's decision this week to voice support for the irresponsible practice of deliberately exposing children to chickenpox as an alternative to vaccination is gravely concerning. The stance that Governor Bevin defended of a student filing suit against Kentucky's health department's vaccination requirements highlights urgent needs for public education on the value of medical immunizations and for policies allowing exemptions only on the basis of medical contraindications. Events in recent weeks also demonstrate consequences of vaccine avoidance. Right? We see this in the mumps outbreak up at Temple University. And there's, like I said, there's 6 states, I think, battling measles outbreaks in the country as we speak. Vaccinations are critical to protecting not only the health of those receiving them, but also the health of those contraindicated from receiving them, including children who are too young or immunocompromised individuals who depend on the protection of herd immunity. That's a term you've heard on this show many, many times, provided by the high community vaccination rates. So, yeah, so Bevin, he may be a great governor in a lot of aspects, but in this particular thing, I think he's dead wrong, and clearly so do others. Do you think you're allergic to penicillin? Well, chances are, though, even though you may think you are, you're probably not. 9 out of 10 people who believe they're allergic to the antibiotic either aren't allergic or have only some intolerance. And 8 of 10 people who had an allergic reaction to penicillin 10 or more years ago will now be fine. And this is from researchers from McMaster University up in Canada. And they basically published 5 facts in the Canadian Medical Association Journal concerning things you need to know about penicillin allergy. And let me see if I can get through these in the first half. Penicillin allergy is commonly reported, but 9 times out of 10, a patient can tolerate penicillin. About 10% of people report a penicillin allergy, but 90 to 95% are not truly allergic. Reasons for this include mislabeling intolerances as allergies and the waning of allergy over time. 2, penicillin allergy is lost over time, with 50% of people over 5 years and 80% over 10 years losing their allergy. Those who had reactions more than 10 years ago are unlikely to still be allergic and should be tested before given penicillin. If there is a strong indication for antibiotics, an allergist physician should be consulted about the therapy. A penicillin allergy label is bad for patients and the healthcare system. People labeled with penicillin allergy are often more costly and less effective, or offered more costly and less effective and broad-spectrum antibiotics, which may have significantly increased risk of infections such as MRSA and C. diff. And patients who suspect penicillin allergy can be identified to determine if they should be seen by a specialist. A side effect of penicillin, such as nausea, should not be noted as an allergy. As well, people without a personal history of penicillin allergy or who have tolerated penicillin in the past do not need to avoid penicillin. Severe allergic drug reactions causing hospitalization due to widespread skin blistering, organ failure, joint swelling are pretty rare. And of course, these patients should strictly avoid penicillin. And then allergy referral and testing is underused, but it's safe and accurate, fast, and it's pretty cost effective. Allergy testing over 1 to 2 hours using a combination of skin and challenge testing by trained personnel have been shown to be safe and effective for children and adults close to about 100% of the time. So if you are a patient who thinks you might have a possible penicillin allergy, you should talk to your doctor and see if you can determine if penicillin allergy testing is necessary. All right. Getting close to the break, I encourage you to check out the website, outbreaknewstoday.com, outbreaknewstoday.com. And after the break, I'm going to be playing a little bit of an Outbreak News TV show with Dr. Glenn Laverack. See you then.
Outbreak News This Week, your source for all the news about worms and germs. Here's your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, welcome back to the show. And let's go ahead and switch gears quite a bit. As some of you know, I've started a YouTube show. It's called Outbreak News TV. And my most recent guest was from the UK. His name is Glenn Laverack, PhD. And we spent, 35 minutes talking about health promotion and the response during outbreaks. And it was a very interesting conversation. And I'm going to play a segment of that here on the second half of this radio show, talking about a lot of different things like the Ebola outbreak and some other big outbreaks and the role of health promotion. So let's go ahead and take a listen to that. Dr. Glenn Laverack, thanks for joining me today from the UK.
Hi, Robert. Nice to be with you. Thanks for inviting me.
Let's start out with an introduction. What is your professional background, and what do you do currently?
My professional background is working internationally in public health, both in infectious diseases and in non-communicable diseases. And at the moment, I'm working, for the last 3 or 4 years, I've been working as an independent advisor, mostly to UN agencies in the Eastern Mediterranean, for example, and in Central Asia.
Can you give us a definition of what health promotion is, and what's its role in disease outbreak response?
Simply put, health promotion is about enabling people, that's individuals, families, communities, to gain more control over their lives, so over their health and over the determinants of their health. You know, in public health now, we talk very much about the causes of poor health, the determinants, things like employment, transport, housing, good nutrition, for example. So at the very nub of what we're doing in health promotion is about giving people more control, and that might be through education or through skills training. It might be about helping them to organize themselves better collectively so that they can take action. It's not just about education. It's not just about imparting information. That is what we did before, and we called it health education.
Is it only applicable to ongoing outbreaks, or is it an integral part of outbreak prevention?
It's very much part of the 3 stages, really. It's very much part of prevention. So enabling people, for example, to be more aware of the risks, how they can become ill from infectious diseases. So, for example, using preventive measures like bed nets. It's very much part of an ongoing outbreak about mobilizing people to collectively come together to take action. So, for example, getting communities to clean up the environment to prevent mosquito breeding sites might be one example. But it's also part of the post-outbreak phase, the recovery phase. So it's about working with to address issues around stigma. It's about counseling. It's about bringing people together in self-help groups to deal with, the post-recovery, the post-outbreak, the recovery phase in terms of getting their lives back together. And it's about using people to do peer education. With the Ebola outbreak, for example, I worked a lot with survivors of the Ebola outbreak to bring them, not only to help them recover, from Ebola, but also to bring them back into the workforce. So this is all what we would consider part of health promotion.
Okay. Well, let's take a look at some recent and some current outbreaks. And I want to start with Ebola. You were very much involved with the Ebola outbreak in West Africa in 2014, 2016. And the current DRC outbreak, there's some differences between the two, right? And one of the major ones are, the current one has lots of issues with armed groups and violence and the like. Can you talk about the role of health promotion in these 2 outbreaks and the different tools that might be necessary?
Yeah, with the West African outbreak, you're right. They, in the DRC, it's moved up a level in the sense that the people on the ground there are talking about much more resistance, community resistance, and involvement of rebel groups. There's more than one rebel group. There are many rebel groups that are physically attacking, for example, Ebola treatment centers and health workers. But of course, there was resistance also during the West African outbreak, particularly in Guinea. And the sort of tools that we used to try and help us to understand better what was happening on the ground were things like mapping. We set up a GPS mapping system where we collected every week reports of violence or incidents in the field from the police, from the peacekeeping forces, and from health workers. And then we used a criteria, for example, to identify a range of the severity of these incidents, and then we map them using a GPS on a visual, computer screen for each district in each country. And this helped us understand, partly where the hotspots were and why it was happening, because in countries there can be a history of community resistance, there can be a history of violence linked to poor governance, linked to corruption, linking back to colonial systems. So this really helped us to understand and to avoid and to work better. And then we set up a system, a sort of traffic light system, where we had a red, amber, and green system, where communities that we had no prior contact or where there was resistance, we labeled this as sort of red zone, so that going into that community to work with that community was done in a very cautious, systematic way. We had amber communities, which we had already worked with, or agencies had worked with, where we could go in and talk to, let's say, the village chief or the faith leader. And then we had green areas where there was constant, regular contact. So I don't know if they're using these systems in the DRC. Resistance, reticence also to be involved in programs is not new. Not just in West Africa or in the DRC, in other parts of the world. To me, what it comes down to in health promotion is, how we are gathering the data, how we are collating it, and then how we are using that to engage with communities. Community data collection and community engagement are two key pillars in the work that we do in health promotion.
One of the things I found very fascinating about your book, and in general, is the topic of handling burials in an Ebola outbreak. And of course, this is a main cause of spread, and including knowing and understanding the differences among the different religions. Can you talk about this and its importance?
We could see early on in the outbreak, Ebola virus disease outbreak in West Africa, that from the epidemiological data, that the spread of the disease was related to funerals, was related to burials. You could see a mini explosion of cases that could be traced back to a funeral. These are unsafe burials. And so, fairly early on in the outbreak, this was identified as a main cause of spread and something that had to be properly managed. Unfortunately, it wasn't properly managed at the beginning. Teams would go in to remove bodies, for example, dressed in full PPE, dressed in full personal protective equipment, which I don't know if you've seen that, but it's like a sort of spaceman outfit going into communities, and not being very sympathetic, if you like, either in terms of the faith of the family or in terms of the respect that was given to people. And so as the outbreak progressed, it became fairly clear that we didn't have to talk about safe burials, but we had to talk about safe and dignified or respectful burials. And this is where, again, health promotion is very important, because teams were set up in which you would have somebody that was there to impart information to the family and to the community about what was going to happen. There would be a representative, for example, from the faith group of that family, of that community, if it was requested. And the bodies were bagged and taken away in a respectful way. And we developed, I was working at that time with the World Health Organization, working with them to develop a set of guidelines for different faith groups. In that part of West Africa, it was principally Muslim, it was Christian, and it was animist. And we focused on Christian and Muslim groups. And there were ways in which, for both faith groups, in which with the family having no direct contact with the bodies, because obviously the bodies, a dead person is still infected with Ebola. So we had to absolutely stop any physical contact, but it could be done in a respectful way so that people could pray, people could do ablutions, for example. People could do various steps, fulfilled their faith requirements without having any, disrespect or without having any physical contact. So in the book, I talk very much about how this was done. And I talk about also how we tried to work with the burial teams, partly in terms of training them to be more understanding of different groups, different families' needs, and also in terms of just simple things like just properly using personal protective equipment. So I have some tools or some training activities in the book that talks about how we did this in the field. So health promotion is, as I said earlier, is helping people to take control. So it's helping people to gain the knowledge, to gain the necessary skills, and it's helping us to work in partnership in this context in terms of a safe and dignified burial, in partnership with the family, with the community, which means that it's better for everyone. It's more respectful to the family and to their religious beliefs, and it's more efficient and effective in terms of the the need to collect bodies and to have them removed.
Dr. Laverack, how is health promotion the same, and how is it different when we're dealing with a vector disease outbreak like the recent Zika and Chikungunya outbreaks?
Yeah, it's in the book, I have a chapter which I talk about specifically the Ebola outbreak because I think this highlights a lot of the key issues around working from a health promoting point of view in an infectious disease context. But then I have two other chapters, one which talks about person-to-person contact, spread of disease. So I talk about avian flu and cholera and polio, for example, and MERS, and one which talks about vector-borne. And I do talk about Zika and Chikungunya, I talk about yellow fever, and I talk about Nipah as well. This is the way I've decided to do it in the book, and after talking to people in the field, what they would get most out of reading the book in terms of, it's written in a very simple way. It's meant to help them, in the field. With something like Zika and Chikungunya, we're talking about a fairly similar means of transmission. We're talking about mosquitoes. So we're talking, health promotion here, imparting information and skills to help people to have more personal protection from mosquito bites. It might be about targeting specific groups, for example, pregnant women within the community specifically with information. It's about working with, in this context, it's about working with the community to help them around surveillance, to help them, for example, to helping them identifying breeding sites for mosquitoes, so that they can be dealt with, rather than the authorities themselves having to find potential breeding sites. For example, in the Pacific, in Fiji, I was working there with communities in a rural context where we set up community committees that had a sort of policing role, if you like, and they would go from house to house looking for potential breeding sites of mosquitoes for malaria. And then, households that were not complying, that, were not covering their water tanks or whatever it was, they would be contacted by the village committee and asked to do so. So it's in health promotion, we're not just trying to direct information down to the community, because we know from experience that communities, individuals and families don't always listen to what we want them to do, or will not change their behavior. But by working with them in partnership in this way and helping them to manage, let's say, for example, in terms of cross-border management of people, or having a community quarantine, for example, for them to manage that, the evidence shows that this can be much more effective. What was interesting for me with the Zika outbreak, I was working on this for a while with the World Health Organization, was, as you know, it changed. It started out as a vector-borne issue. So we were there talking about, personal protection on breeding sites and giving people particular information about healthcare. But then it switched to also being transmitted through sexual contact, and therefore we had to be flexible and switch. And I think switch our advice. And I think this identifies a really important point about health promotion, which I try to bring out in the book in Disease Outbreaks, because we talk a lot about strengthening systems within countries for surveillance, and strengthening the health system, and strengthening healthcare systems for future outbreaks. But we don't really talk about strengthening the health promotion aspect of disease outbreaks. And when there is an outbreak at the country level, the health promotion department, or the health education department, whatever it's called within the Ministry of Health, is normally the first point of contact for communication strategies, but also for community engagement. And if the capacity is weak, and it often is in many countries weak, within the Ministry of Health, then the level of work that can be carried out is very limited. So I think it's very important for preparing for the next outbreak, if you like, in a particular country. We should be putting just as much emphasis on these issues of how we can develop a better communication system, how we can develop a better network of community-based organizations, because this is the link between the gap between state services and civil society. There's often a gap between those two levels, and what bridges that gap is a good network of civil society organizations through which we can work to actually get better access to communities and to families. And we found this in the West African outbreak, for example, that nobody really had a handle in the 3 affected countries in West Africa at that time on which NGOs were working, on health issues with which communities. It was assumed that certain agencies like UNICEF would have a good network, but they didn't, in effect, have a good network in the country. So these things need to be strengthened. And where there isn't a good network of civil society organizations that we can work with in communities to help us with things like community quarantines or surveillance or contact tracing, for example, then we need to think about whose responsibility it is and how we can strengthen community-based organizations within the country in preparation for future outbreaks.
Let's switch gears to vaccine-preventable diseases, and we see measles outbreaks peppered throughout the planet. I take it vaccine promotion and education is key, but what else?
Yeah, I mean, you're absolutely right. And that's the great thing about Outbreak News, Robert, is that it reminds us all the time that there's outbreaks going on all over the world, right? All the time. I mean, and in some countries we have more than one outbreak happening at any one time. It could be measles, and it could be a vector-borne disease as well. It could be polio, and it could be a vector-borne disease, or it could be cholera, So, and most outbreaks don't get the international attention that the Ebola outbreaks have had. I mean, I think it's fair to say that the West African outbreak, for example, for Ebola, was a global response. That was my perspective, being on the ground. But it was never really, I think, a global threat, But for most outbreaks, it's left to the country to handle the issue, be it, whatever it is, because often these outbreaks are fairly localized to begin with. And there's not much that WHO, for example, can do at the country level, to actually help in terms of resources. So this is why, going back to what I said earlier, we need to think about strengthening the capacity of the departments for health promotion within countries so that we can do this to help, to do communication and community engagement to enable others. Where there is a vaccine, and in the book I talk in one chapter specifically about how we can work with communities to promote vaccine. Where there is an effective vaccine, for example, with measles and polio, obviously our emphasis is on increasing awareness, creating a supportive environment where people can get access to the vaccine, being sensitive to the cultural issues. I feel that an area in outbreaks that is really missing is one around cultural competence. We often don't understand the social cultural aspects of what's happening in that country, and we do make mistakes because of that. Anthropology helps us. Anthropology is absolutely essential to help us understand the social cultural issues, around encouraging people to uptake vaccines or encouraging people to use bed nets, for example. But to be honest, when there is an outbreak, the situation is changing on a daily basis. The situation is changing even on an hourly basis. And what we need is, we do need social science, but we need, in a way, quick and dirty information. We need rapid information that we can translate into programmatic recommendations. And anthropology is a slow science. And we don't have weeks or months in order to get the findings from an anthropological study when there is an outbreak. So we need this information before. And this is where I think we need more emphasis on anthropology. It's not during an outbreak, it's before an outbreak, or let's say after an outbreak, so that we can find out what went wrong and what happened, and that can be then turned into good programmatic, policy and practice recommendations. So it's not just about education, as you say, for vaccine promotion, where there is an effective vaccine, but it's about involving people in helping us to organize, running out these vaccines. Working with, for example, the polio outbreak in Afghanistan and in Pakistan, for example, has been very effective because it's engaged with significant people in the community, like faith leaders and community leaders who've had their children vaccinated for polio publicly. And this is being used as a means to, encourage other people in the community to get their children vaccinated. So engaging with the community, bringing them on board with a partner, as well as giving, good, simple, but good information is the way forward. It's not just about us giving information using some various form of media or even face-to-face communication or posters. We have to properly engage with, and that's why in the book I give a whole chapter to community engagement and how it can be done in a systematic way.
All right, so if you want to listen to the rest of that interview, it's Outbreak News TV on YouTube. And Professor Laverack is a public health expert, and he's very, very knowledgeable on this topic of health promotion that a lot of people might not think about. Okay, well, I did a post on the website outbreaknewstoday.com, and I looked at some of the recent vaccine preventable disease outbreaks, particularly the measles, and then of course that tetanus case from about a month ago that was reported. It was actually from 2 years ago, but they really talked about it after the CDC report a month ago. And I go over a lot of the different costs, right? I mean, we're talking like tens, hundreds of thousands of dollars investigating these measles outbreaks. Sometimes it's just one case too. And also the massive hospital bill. This child in Oregon who contracted tetanus in 2017, it was like $800,000 just for the inpatient charges. It's just massive. So I encourage you to check that out at outbreaknewstoday.com. Okay, I'm going to wrap things up here. I want to thank Michael for running things, as always, and I will see you next week on Outbreak News This Week. Good day. God bless.
Thank you for listening to Outbreak News This Week with Robert Harriman. If you missed any part of today's program, you can listen to the podcast anytime on our website, outbreaknewstoday.com. Make sure to join us here next week for Outbreak News This Week with Robert Harriman.